Are you trying to conceive and still not being successful at it? Well, even if your reports are normal and you're not able to conceive, there might be something that you are born with and you don't even know about it. Yes, I'm talking about septum, uterine septum. What is uterine septum? How does uterine septum affect fertility? How does uterine septum affect pregnancy? Does uterine septum causes any complications during pregnancy? How to diagnose uterine septum? How to treat uterine septum? Does uterine septum require treatment at all? Do we require to remove uterine septum before an IVF? We'll discuss all these questions in today's very short but interesting video. Good morning, good afternoon, good night, wherever you are. I'm Dr. Rajat and you have started watching our YouTube channel, The Fertility Gynecologist. Septate Uterus. सर आपको पर्दा है, सर मेरे को पर्दा बोला गया है, क्या उसका ट्रीटमेंट करना पड़ेगा? This is what we will discuss. So for all you know, what is septate uterus? It is like a curtain inside the uterus. This is the uterine cavity and there is a septum inside. Septum in layman language we call it as a curtain. In Hindi we call it as parda. There is a septum inside and it is a congenital condition. It is a benign condition and it is one of the very common conditions. There are various definitions of uterine septum. It is a deviation of a normal anatomy which is as a result of an embryological maldevelopment of a Mullerian or a paramesonephric duct. Yes, it is a bit technical, but to tell you the truth, basically this single uterus develops from two semi-uteruses from both the sides. They come together in the midline, join, and then there is a reabsorption of the midline, this thing, and then it becomes a complete uterine cavity. So whenever there is any problem, embryological problem, it leads to a septum. This defect can be in the fusion of two hemiuteri. This defect can also be in the absorption of their connective tissue, which seem to be responsible for the septate uterus, and these events usually occur before the 20 weeks of pregnancy. It can be complete uterine septum, it can be an incomplete uterine septum, it can be broad, it can be thin, it can be short, it can be long, it can be vascular. There are various variations. One another variation of a septate uterus, which although not technically called as a septate uterus, is an arcuate uterus. There is a mild dimpling on the top of the uterus. An American Fertility Society says it is not actually a part of a septate uterus. There is a fundal midline indentation which is less than 10 millimeter and the indentation angle is less than 90 degree. Sorry, it is more than 90 degree in arcuate uterus. While in the septate uterus, this midline indentation is usually more than 10 millimeter and the indentation angle is less than 90 degree. Between 10 to 15 millimeter. In arcuate uterus, it is an indentation which is less than 10 millimeter. In septate uterus, the indentation is more than 15 millimeter, and between 10 to 15 millimeter is a gray area. According to the ASHRAE or the ESG, European Society of Gynecology and Endoscopy, the septate uterus has an outline which is normal, but internal indentations, they exceed 50% of the uterine wall thickness. This is the uterine wall thickness, and if the indentations which are inside they exceed more than 50%, it can be a partial, it can be complete. Partial means it will only half partially divide the cavity, complete means it will reach up to the internal os. Well, there is a congenital uterine malformation by experts CUME classification which says that when the depth of indentation is more than 10 millimeter and the indentation angle is less than 110 degrees, or when the indentation to the wall thickness is greater than 110, it is called as septate uterus. For all practical purposes, there should be two things. One, there should be indentation, which should be acute angle less than 90, and there should be a deviation inside, the septation inside, which should be more than 15 millimeter. That is called as septate uterus. How common is septate uterus? It is very common. It is seen 2 to 3% of the general population. In about 15 to 40% of the patients with recurrent pregnancy loss, septate uterus is seen. The possibility of a spontaneous pregnancy with a septate uterus is significantly low, and septate uterus, if they conceive, they are at higher risk of first and second trimester abortion. In pregnancy, what does septate uterus cause? It causes malpresentation. There are more incidents of breach. There are more incidents of transverse lie. It causes fetal growth restriction. I'll come to it later. Why it causes? It also causes increased chances of placental abruption. It causes increased chances of preterm delivery, spontaneous preterm labor, and thereby the preterm baby and perinatal mortality. Now this septate, why I have chosen this topic today, this septate uterus there is a difference in the architecture of the endometrium of the septate uterus and the myometrium beneath the septate uterus. The architecture of endometrium has got less Hoxa genes. The myometrium has got abnormal musculature, and thereby it impacts the implantation of trophoblast on it, and therefore the chances of spontaneous pregnancy decrease. Now most of the people, they do not know, it is not seen outside the body. That is why most of the people cannot know. It is only when you visit a gynecologist or a radiologist that they'll diagnose it, this modality. So the most common earlier, it was an HSG, hysterosalpingography. We put a dye inside the uterus, and then dye will fill the cavity of the uterus. It will go through the fallopian tubes, and then it will tell us whether the septate uterus is there or not. But nowadays we do not rely on hysterosalpingography for the diagnosis of a septate uterus. We do a good transvaginal 3-dimensional ultrasound, which has got a 80% sensitivity for diagnosing the septate uterus, and if it is combined with saline sonography, we inject the saline, then it is almost 100% accurate to diagnose the septate uterus. Now the most important thing before we ask about the treatment part is the embryology part. Embryology means when the fetus is inside the uterus from 4 weeks, 6 weeks, 8 weeks till the growth, how the septate uterus is formed. Like I said, there are mesonephric ducts, Mullerian ducts or paramesonephric ducts. 2 hemiuteri come from lateral, go inside in the midline, they fuse, and then first is the fusion, and then the center part is reabsorption. This occurs. So there can be an abnormality in the fusion, there can be an abnormality in the reabsorption part, and this is very, very important. So septum occurs when the 2 hemiuteri fuse, but they do not reabsorb fully or partially reabsorb. The remaining non-absorbed tissue at the top of uterus behaves like a scar tissue. It has got a decreased blood supply, it is more fibrous, it has got lack of receptors which are found in normal endometrium, and as a result the normal pregnancy does not implant on it. Between 7th to 9th week, it is the fusion of the caudal parts which occur, and there is a formation of a female genital tract, the uterus, cervix, and the upper 2/3 of vagina. And between 9th to 20th week, the reabsorption part of the midline part and the formation of uterine cavity occurs. This process of fusion and reabsorption, they don't occur sequentially. They have a definite overlapping things. The absorption defect might coexist with the fusion defect. Depending upon the embryological defect on each patient, the septum's musculature might have a different consistency. The intrauterine septum consists of both endometrial and the myometrial tissue, and most of which is vascularized. However, sometimes there are lower levels of vascular epithelial growth factors, receptors, and as a result, the histological component of septum is different from the myometrium. Therefore, the septum is a complex structure consisting of the islands of muscle fibers which are irregularly arranged, and the structure is similar to that of a fibroid. Also, the endometrial vascularization of a uterine septum is likely to be present, is altered, and thereby the vascular supply is disturbed compared to the rest of the uterus. That is why the embryology is very important. Now comes the clinopathological correlation of this embryology, that is pathophysiology of the septum. Not all uterine septa are the same. Not 2 females with uterine septa will have similar this thing. There could be an expression of an embryological defect that led to either failed reabsorption of the uterine septum, or in some females there would be a failed fusion. If there is a pure reabsorption defect with a normal fusion, there might be a more fibrous and a less vascularized septum. Thereby, the chances of subfertility may be there. These females may not be able to conceive easily. If there is a mixed reabsorption and obscure fusion defect that is associated with a more muscular septum, and that leads to the abnormal pattern of a muscular architecture and a uterine motility, and these females, they can conceive easily, but they are more prone to a spontaneous preterm and a recurrent pregnancy loss. So the current hypothesis is that main histological background of septa is the alteration in the myometrial consistency at the level of fundus, and this could lead to the alteration in vascularization, alteration in overlying endometrium, alteration in Hoxa genes, thereby problems in implantation and the embryo adherence. Now comes most important thing which most people have there in their mind. How to treat a septa. Long back, years and decades back, people used to do meteroplasty, a septoplasty, which was an open technique. They used to open the abdomen, open the uterus, cut the septum, suture the uterus. Those are years gone by. People no longer do it. There is a term called as Jones and Tompkins type of a meteroplasty. It is abandoned now because nobody does laparotomy. Nobody does in hysterotomy for the same. There is a long period of rest, long period after which the patient can think of conceiving. Nowadays, the gold standard is hysteroscopic meteroplasty. Hystero means uterus, scopy means put a camera inside, and meteroplasty means to reshape the cavity of uterus. If you put a camera inside, there is a thin pencil-like camera inside, you see, and then cut. That is the go-to procedure nowadays. You can cut by a cold scissors, you can cut by a electrocautery. When compared with electrocautery and cold scissors, the number of pregnancy and the number of full-term delivery are slightly but statistically more compared to the cautery. There are two versions of cautery. It can be electro point, and recently the new things have come into the market which is called as a Versa point or a resectoscope and a Versa point. The pregnancy are more with Versa point, but Versa point requires more cervical dilatation. Very few cases we do it by resectoscope. I would prefer to do it by a cold scissors whenever we are going in for a septal resection. Now, the term is septal resection when actually it is an incision. We just cut the septa, and septa, because it is a fibrous or a muscular tissue, the moment I am cutting a septa, it is like this. I am cutting, it gets retracted and it gets reabsorbed. We don't need to resect. When I say resect surgically, means I cut a portion and take it out. In septa, it is a resectum. Resection is actually a misnomer. We do basically an incision on septa. So we are cutting the septa in the midline, equidistant from the both lateral walls or equidistant from both the anterior and posterior wall. Now whenever we are cutting the septa, we do a simultaneous laparoscopy also, because just to be on the safe side that we are not perforating the fundus of uterus. It is still unclear that whether the women who undergo hysteroscopic septoplasty or expectant management, whether the chances of pregnancy are more with septoplasty. But in patients with recurrent IVF failure, or patients who are going to undergo IVF, or patients with recurrent pregnancy loss, or patients with history of spontaneous preterm labor, in those patients, septal resection is required. The recent research has also shown that instead of a laparoscopy, a good 3D ultrasound along with hysteroscopy may also work in the same way as laparoscopy to prevent the resection. In very few cases, if there is an excessive septal resection, there is an excessive penetration of the myometrium, there can be a uterine wall perforation. And because why I say that cold scissor is better than a electrocautery or a Versa point, whenever we are using an energy sources for cutting the septum, there is a mild, very small but significant amount of a lateral spread. Now that lateral spread we are not able to see at that point of time, but that lateral spread leads to the necrosis of the surrounding tissue. That lateral spread might be only 1 to 2 millimeter. So if we do slightly more septal resection, there are chances that myometrium, that 1 to 2 millimeter of myometrium which is normal, may get necrosed and the myometrial wall may become thin. So how do we decide how much to resect the septa when we are undergoing the hysteroscopy? We cut the septa, and like I said, because septum is mostly an avascular structure, if it is a fibrous structure more, we cut till the point we cut by millimeter by millimeter. We don't cut centimeters, we just cut millimeter by millimeter, and it keeps on retracting on either side. And the point at which the bleeding starts coming, we stop, because that bleeding, like I said before, the musculature is more, because of bleeding musculature is more vascularized and that may bleed. So the moment there is bleeding starts coming, we stop. Another endpoint is we should be able to see both the ostia at the same time. The moment we are able to see both the ostia at the same time, then we are okay. We don't need to do a full concave shape correction. We don't need to do, even if slightly 1 to 2 or 5 millimeter indentation is left, that is fine. Till 10 millimeter indentation is fine, because that will come into the category of an arcuate uterus, and pregnancy can easily occur along with the arcuate uterus. Now, few frequently asked questions which people normally ask me in my OPD. Does a septum affect fertility? While there is an insufficient evidence for a definite evidence that septum does produce infertility, the females with septum have got a subfertility. They find it relatively difficult to conceive. The chances of spontaneous conception with septum are relatively less. Does septum contribute to a pregnancy loss or an adverse pregnancy outcome? Definitely yes. Septum is associated with chances of recurrent pregnancy loss, recurrent preterm labor, spontaneous preterm labor. It is also associated with complications in pregnancy like abruption of placenta. It is also associated with prematurity, preterm. There can be a breech presentation, there can be a transverse life, fetal growth restriction. Now, I said fetal growth restriction. If the placenta is implanted partly on the septum, because septum is less vascularized, the blood supply from the uterus to the placenta in that portion where the septum is there may be less, and that is why the fetus may get less blood from the mother and there would be a restriction. Is septum resection required in all infertility patients? Answer is no. If all other factors are normal, if the patient's past obstetric history is normal, or patient has got no history of recurrent pregnancy loss, no history of spontaneous preterm labor, then we try it normally. We go in for a shared decision-making model. We tell our patients to wait for 9 to 12 months before taking some kind of an action on a septum, because like I said, arcuate uterus is one of the part of family of septate uterus. It is also called as subseptate uterus, and less than 10 millimeter indentation, indentation or the septum does not require any surgery. Does treating a septum improve an obstetrical outcome? I said the chances of breech delivery would decrease, the chances of transverse life would decrease, the chances of spontaneous preterm would decrease. So yes, it may decrease the chances of adverse outcome in the obstetrics. Now, some people routinely use preoperative thinning of endometrium during the septal surgery. Is it required? While doing hysteroscopy, if the endometrium is more and fluffy, then the chances are that you may not be able to clearly visualize the septum, or because of the hysteroscope, the endometrium may get sloughed off and the field may not become clear. So in an ideal world, the endometrium should not be much for septum resection, but what we do is, we do it in the early proliferative part of the cycle. First 3-4 days once the bleeding stops. Once 3-4 days of bleeding has stopped, then when the endometrium is relatively thin, 4-5 millimeter, then we do the septum resection. There is no need of artificial agents to thin the endometrium. Can cervical insufficiency be induced by septal resection? There is no evidence that septal resection improves the chances of cervical insufficiency. However, in all the cases of septum resection, especially if it is a complete resection of septum, there is a small uterine cavity. And since these are associated with the history of preterm labor, in all those cases who conceive with a septum resection, it is advisable to go for a prophylactic septal cervical cerclage to prevent the incidence of a threatened preterm or a preterm labor. Now, like I mentioned before, sometimes what happens is that there is a residual septum of less than 10 millimeter. Do we need to remove it? Answer is no. Less than 10 millimeter septum, we do not need to remove it, because it will more or less mimic an arcuate shape uterus. An arcuate shape uterus is not an abnormal uterus, it is just a variation of normal uterus. After septal resection, like I mentioned, if this is the septum, inside the septum retracts, but there may be a raw denuded area. Do we need to go for adhesion prevention methods? There are 4 things which normally people do for adhesion prevention. Some people use estrogen for covering the denuded area so that the epithelialization occurs. Over that, the denuded area is not there and there are less chances of septum getting fused back again. This is not possible. Septum, I have not seen regrowing back again. It cannot fuse once it is inside, because since there is some component of a muscular tissue in the septum, it retracts in the myometrium and it will not grow back. So there is no routine indication of giving estrogen for covering or fast reepithelialization. Some people give good antibiotic prophylaxis. Again, the research or an evidence does not prove that giving routine antibiotic prophylaxis is required. However, after the septum is resected, there may be chance that intrauterine adhesions or Asherman syndrome may occur. So for that, some people put a copper T on an IUCD for some time to prevent the adhesion, to prevent the Asherman syndrome, that can be kept for 3 to 6 weeks. It can be removed after the next menstrual cycle. That is a good established practice. Sometimes some people also use intrauterine balloons. Follis catheter is filled and kept for 2 to 3 days for prevention of adhesion. That, in my opinion, is not required. An excessive filling of balloon may sometimes lead to a uterine rupture. The chances is very, very less. However, if there is an excessive bleeding during the septum resection, for control of that bleeding, we can inflate a Follis catheter, fill the balloon by about 2 to 3 millimeter, and that can lead to the pressure hemostasis, and that can resolve the bleeding. We can remove the catheter after 24 to intrauterine Follis catheter after 24 to 48 hours. Most important question is there an increased risk of uterine rupture in the subsequent pregnancy? Chances are very, very less. But like I said, to each one to its own, you have to individualize. You have to see the chances of uterine rupture with cold scissors and an optimally, not an excessive septum resection, but an optimal septum resection are almost zero. But chances of uterine resection, the uterine rupture after a septal resection, for an aggressive surgeon, for an hyper enthusiastic surgeon who does slightly more correction, uterine thinning may be there, or an excessive use of cautery for the bleeding at the septum that may lead to the thinning of the uterus. Those cases may occur. So whenever a patient with septum resection comes to me, I usually ask for the photographs and the video of a hysteroscopic septum resection to make my mind how much possibly the damage to the fundus myometrium may be there. And in those cases, if there is a full thickness septum resection which has been done, I usually do not ask the patient to go for a normal delivery. It is better to go for a elective section at 39 weeks. So in conclusion, an incidentally diagnosed septum which is less than 10 millimeter does not require any surgical treatment. Patient can be managed expectantly. Septum resection should be done for females who have got history of recurrent pregnancy loss, history of preterm labor, or history of IVF failures. I would recommend to go for septum resection before a patient goes for IVF, even if it is a ARCUATE uterus, because it slightly increases the chances of pregnancy. And for all those patients who have got big septum and septum resection has been done, it is better to go for elective LSCS, although the chances of rupture are very, very less. But it is better to go for elective LSCS, or do not give a prolonged trial. A short 8-10 hours trial should be given, and then the decision should be taken for delivery. Please like the video, please share the video, and please subscribe to our channel. Thank you. Bye-bye.